Welcome to today's lecture on artificial intelligence in medicine. Today, we'll debunk common myths about AI and explore its fascinating history and evolution in healthcare. Let's begin. Part 1. Debunking common myths about AI in medicine. Before we dive into the technical details, we need to address 3 persistent myths about AI in healthcare that you'll encounter throughout your career. Understanding these myths now will help you become more effective physicians in an increasingly technology-driven medical landscape. Myth number 1, AI will replace doctors. This is perhaps the most common misconception, and I want to be absolutely clear. It simply isn't true. AI is a tool that augments clinical practice. It does not replace physicians. Think of AI like a stethoscope or an ultrasound. It's sophisticated technology that enhances your capabilities, but it cannot do several critical things that only you as a physician can do. AI cannot empathize with patients during difficult diagnoses. It cannot navigate ethical dilemmas in end-of-life care. It cannot take legal and moral responsibility for patient outcomes. It cannot integrate complex social determinants of health into treatment plans, and it cannot build therapeutic relationships that improve patient adherence and outcomes. Let me give you a concrete clinical example. An AI algorithm might flag a suspicious lung nodule on a CT scan with 95% accuracy. That's impressive, but only you can sit with the patient, explain the findings, discuss their smoking history, address their anxiety about cancer, and create a personalized follow-up plan that considers their job, their family situation, and their personal values. That's the art and science of medicine that no machine can replicate. Myth number 2, AI is always accurate. The reality is that AI is only as good as the data it learns from. There's a fundamental principle in computer science: garbage in, garbage out. This applies directly to medical AI. AI systems have several important limitations. First, bias in training data. If an algorithm is trained primarily on data from one demographic group, it may perform poorly on others. Second, dataset quality issues. Mislabeled images or incomplete medical records lead to flawed predictions. And third, context blindness. AI cannot account for clinical context it wasn't trained to recognize. Here's a real-world example. An early AI skin cancer detection system was trained primarily on images from patients with lighter skin tones. When researchers tested it on melanomas in patients with darker skin, the accuracy dropped significantly. This illustrates why physician oversight remains absolutely critical. You must recognize when AI recommendations may not apply to your specific patient standing in front of you. Myth number 3, AI makes medical training less important. Actually, the opposite is true. Artificial intelligence makes well-trained physicians more valuable, not less. As future physicians, you need to understand AI capabilities and limitations to use these tools appropriately. You need to interpret AI outputs critically rather than accepting them blindly. You'll need to lead the development of ethical and effective AI implementations in your hospitals and clinics. And you'll need to bridge the gap between technology developers who build these systems and the clinical reality of patient care. The bottom line is this: the physicians who master both clinical medicine and understand how to work with AI will be the leaders shaping the next generation of healthcare. Your medical education is not becoming obsolete. It's becoming more important and more complex. Part 2, the history and evolution of AI in medicine. Now let's step back and look at where AI came from and how it evolved into what we use today. The origins of artificial intelligence. The term artificial intelligence was coined in 1956 at the Dartmouth Conference by computer scientist John McCarthy. But what exactly is AI? Here's a simple definition. AI refers to computer systems that can perform tasks that typically require human intelligence, such as learning from experience, recognizing patterns, making decisions, and understanding language. Early AI rule-based expert systems, the earliest medical AI systems developed in the 1970s and 80s, were rule-based. This means they followed explicit if-then logic programmed by experts. Let me tell you about MYCIN, one of the pioneers in medical AI. MYCIN was developed at Stanford University between 1972 and 1980. It was one of the first expert systems in medicine. Its purpose was to diagnose bacterial infections, particularly blood infections and meningitis, and to recommend appropriate antibiotics. Here's how it worked. MYCIN contained approximately 600 rules in the format. If certain conditions are met, then draw this conclusion. For example, one rule might be, if the infection is meningitis and the patient is allergic to penicillin, then consider chloramphenicol. The system would ask physicians questions to gather information, then apply these rules sequentially to reach a diagnosis and treatment recommendation. The results were actually quite impressive. In clinical trials, MYCIN's antibiotic recommendations were comparable to those of infectious disease specialists. However, and this is important, it was never actually used in clinical practice. There were legal concerns about liability, ethical questions about computer-based decisions, and practical challenges with implementation. But MYCIN's main contribution wasn't its clinical use. It was proving that computers could support clinical decision-making. That was revolutionary. Why was it called MYCIN? It wasn't an acronym. It was named after the suffix found in many antibiotics like erythromycin, clindamycin, and vancomycin to reflect its purpose of recommending antimicrobial therapy. Now, rule-based systems like MYCIN had significant limitations. They required manual programming of every single rule by experts. They couldn't learn from new data. They were brittle, meaning if a clinical situation didn't match existing rules, the system couldn't adapt, and they were difficult to update as medical knowledge evolved. Modern AI, machine learning and deep learning, fast forward to today. Modern AI systems use what we call machine learning. Instead of following pre-programmed rules, these systems learn patterns from vast amounts of data. Let me walk you through current clinical applications across different specialties. In radiology and medical imaging, AI algorithms now analyze CT scans, MRIs, X-rays, and mammograms. They can detect lung nodules, identify fractures, and measure tumor size. As of 2024, the FDA has approved over 500 AI-based medical imaging devices. That's remarkable growth. In dermatology, smartphone apps can photograph skin lesions and assess melanoma risk. Some systems perform comparably to board-certified dermatologists in controlled studies. Apps like Skin Vision exist for this purpose. However, and this is crucial, physician confirmation is still essential. These are screening tools, not diagnostic tools. In critical care, we now have sepsis prediction algorithms that analyze vital signs, lab values, and clinical notes in real time. These systems can alert clinicians 6 to 48 hours before traditional criteria would trigger an alert. Epic's sepsis model, for instance, is used in hundreds of hospitals. But there's a challenge. High false positive rates can lead to alert fatigue among clinicians. This is something you'll need to manage in your practice. In pathology, AI assists in analyzing tissue samples for cancer. It can quantify biomarkers and even predict treatment response. Companies like Path AI and Page.ai have developed platforms for this purpose. In ophthalmology, AI screening for diabetic retinopathy has become quite advanced. There are FDA-approved systems like IDX-DR that can make autonomous diagnoses. This is particularly valuable in areas with limited access to ophthalmologists. And in drug discovery, AI is accelerating the identification of drug candidates. It can predict molecular interactions and potential side effects. AlphaFold's protein structure predictions, for example, have revolutionized drug development. So what's changed from the MYCIN era to today? Modern AI systems can analyze millions of medical images or patient records and discover subtle patterns that humans might miss. They continuously improve as they see more data. However, they still require human oversight, validation, and clinical integration. That's where you come in. Key takeaways. Let me summarize the key points from today's lecture. First, AI is a powerful tool, not a replacement for physician judgment, empathy, and responsibility. You are irreplaceable. Second, AI accuracy depends entirely on training data quality. Your role is to critically evaluate AI recommendations, not blindly accept them. Third, medical training is more important than ever because future physicians must understand both medicine and technology. You need both skill sets. Fourth, AI has evolved dramatically from rule-based systems like MYCIN in the 1970s to modern machine learning that can learn patterns from massive datasets. Fifth, AI applications span every medical specialty, from radiology to drug discovery, but all still require physician oversight and integration. Looking ahead, we'll dive deeper into the most important concept for your clinical practice. The fundamental difference between clinical reasoning and machine reasoning. Will explore how you think as a physician versus how AI systems process information. We'll use a detailed clinical case to show these differences side by side, and we'll give you a practical framework for when to trust AI and when human judgment is absolutely essential. This distinction is critical for your future practice. So I encourage you to think about these questions before our next session. How do you currently approach a difficult diagnosis? What mental steps do you go through? Can you imagine a computer doing the same thing? Why or why not? Thank you for your attention. I look forward to seeing you in the next one, Clinical versus Machine Reasoning.